Hello, everyone, and welcome to the 1000 Eco presentation. And thank you all for being here today. I'm Laura Musteti. I'm an adult and psychosomatic medicine psychiatrist, and I'm practicing at St. Luke Behavioral Health Clinic in Boise. I had the privilege of consulting on patients with psychiatric symptoms seen in long COVID clinic led by Dr. Donovan at St. Luke. Before we dive in, I have no financial or relevant disclosure to report. Today's presentation focus is long COVID and its impact on mental health. I'm sure many of you have worked with patients facing these symptoms and have encountered some difficult psychiatric presentation along the way. Next slide, please. By the end of our time together, my goal are for you to feel more confident in identifying the major mental health symptoms associated with long COVID, describe common recovery trajectories, and apply a multi-model evidence-informed treatment framework. If questions come up at any point, please drop them in the chat, and I'll do my best to answer them at the end. Next slide, please. Let's start with a quick look back, just orient ourselves. So COVID-19 was first reported in Wuhan, China in late 2019. By May 2020, reports of persistent symptoms after the acute infection had started surfacing, often coming from patients themselves long before we had a name or a framework for the condition. By early 2021, what we now call long COVID had gained broader scientific and clinical recognition. How we define the long COVID? Long COVID is a chronic infection-associated condition that begins within 3 months of the initial COVID-19 illness, persists for at least 2 months, and cannot be better explained by another diagnosis. The most widely recognized definition, long COVID is a condition with persistent, fluctuating symptoms affecting multiple body systems that continues 4 to 12 weeks or longer after the COVID-19 infection. Next slide, please. Going over some statistical data, late 2022, an estimated 77.5% of the US population had experienced COVID at least once, and long COVID prevalence had shifted over time with a peak of 7.6% documented in summer of 2023 that decreased over time to roughly 5.3% by late summer 2024. Is long COVID a medical issue, a public issue, or an economic one? It is all three. The global economic impact is substantial, about $1 trillion annually, which is roughly about 1% of the global GDP. The burden touches individuals and their families, healthcare system, and national economies. We talked about in the definition that long COVID affects multiple body systems. So there were about 200 symptoms reported. Among those many symptoms, a few rise to the top as the most common, which is fatigue, cognitive impairment, often described as brain fog, and anxiety and depression. Importantly, long COVID is highly heterogeneous. Every case begins with a COVID-19 infection. However, the subsequent course can vary dramatically from one patient to the other. There are several patterns observed over time: persistent symptoms, fluctuating symptoms, relapsing, remitting, worsening over time, or no recovery reported at 12, 24, or even 36 months after the diagnosis. Long COVID can affect children and adults who have experienced mild, moderate, or severe acute illnesses. Next slide, please. Let's talk about who is at greatest risk. Patients who are female or older are more often affected. The more severe the initial infection is, especially ICU level severity, the higher the risk. Health disparity also matters. Patients facing financial or structural barrier often remain symptomatic longer. Many prior conditions can increase patient susceptibility to long COVID, as the illness can be layered on top of multiple chronic conditions such as psychiatric disorder, asthma, diabetes, obesity, immunosuppression, cardiovascular, kidney disease, smoking, low physical activities. There are few protective factors. Vaccination significantly reduces the risk. mRNA vaccines appeared to be most protective, and even post-infection vaccination had shown benefit, with the Omicron variant and newer viral strain having been associated with lower long COVID risk. We all have seen patients who are young, previously healthy, fully vaccinated, or mild asymptomatic acute infection who were never hospitalized or had no comorbidity, but they still developed long COVID. The takeaway here is that risk factors shows association, not certainties. They inform, but they do not predict who will or will not develop long COVID. So we need to remain curious, flexible, and attentive to patients' individual experience. Next slide, please. What causes long COVID? The causes are likely multifactorial with overlapping processes. The virus invades the neurons and alters their function. Viral persistence, cellular dysfunction, elevated inflammatory markers, immune dysregulation, autoimmune-like responses, coagulation abnormalities, to name a few. There are a few questions that patients with long COVID often ask. There is a long COVID test. This is a tough conversation, and clarity helps reduce the distress. There are no validated biomarkers reliably diagnosing long COVID. There are no imaging studies that are specific to the diagnosis, and there is no single targeted therapy that exists yet. Another question that patients are asking, how long this will last? Long COVID can last months to several years, and if symptoms are persisting beyond 2 years, the chance of complete recovery declines, though meaningful improvement is still possible. The recovery trajectories are also variable, with patients experiencing steady improvement, fluctuating course, relapsing, remitting, worsening over time. Next slide, please. There are predictors of improvement, with the strongest one being vaccination, and factors linked to delayed or poor recovery, with the strongest predictor of non-recovery being the severe fatigue. Next slide, please. I suspect you've seen that mental health symptoms are as disabling as the physical one. Roughly 1 in 4 long COVID patients are experiencing psychiatric symptoms that can be new onset disorder, but also can worsen pre-existing ones. High rates are observed for anxiety, mood disorder, suicidal thoughts, insomnia, cognitive impairment, psychotic disorder, and substance use. Few important findings are that risk for cognitive deficits, dementia, and psychotic disorder can remain elevated up to 2 years from the diagnosis of long COVID, in opposition with anxiety and depression symptoms that tend to start declining around the mark of 6 months, although it does not happen for every patient. These risks are higher than after influenza or other respiratory infections, suggesting there is something distinct about COVID-19 neuropsychiatric impact. Next slide, please. I want to acknowledge that many patients have told us that their symptoms were dismissed or minimized. Stigma remains widespread, leading patients to delay care, reduce their engagement in treatment, and experience worsening mental health. For many, the invalidation itself is as distressing as the illness. Regarding coordinated recommendation, the APA advises maintaining a low threshold for screening and treating mental health condition in long COVID. This includes routinely assessing pre- and post-COVID symptoms to identify new, worsening, or persistent concerns early. Routine care should also include screening for suicidality. Please do not wait for the symptoms to settle on their own. Next slide, please. Management is complex and requires a multimodal collaborative approach. Ideally, patients receive care in multidisciplinary settings with clinicians familiar with long COVID. Such settings remain an ongoing logistical challenge that pushes us to keep refining our care models. What should a multimodal care include? There are few rehabilitation services that can help patients. One is pacing-based rehabilitation, different than the traditional progressive exercise. It is recommended for individuals with long COVID, as this patient tends to overexert themselves on days when they feel better, which often leads to symptoms of crash. Pacing offers a safer and more effective strategy because unmoderated or forced exercise can trigger inflammation and worsen post-exertional malaise. Then you have integrative supportive interventions such as acupuncture, massage, yoga, lifestyle intervention, sleep management, stress reduction strategies, functional support, especially in workplace or academic accommodation, which help this patient function somewhat better. Cognitive rehabilitation focuses in addressing the brain fog, which is often among the most disabling symptoms. Cognitive rehab includes specialists in neuropsychology, occupational therapy, and speech-language pathology that can help identify deficits, tailor strategies, and track progress. Then you have pharmacological intervention that should be individualized with focus on early recognition treatment and ongoing monitoring to reduce long-term disability, lower symptom burden, and improve function. Next slide, please. And not the least, psychotherapy that plays a central role with helpful modalities, including cognitive behavioral therapy known as CBT, trauma-informed therapy, group therapy. CBT can help patients who feel overwhelmed, are experiencing depression or anxiety, trauma-related symptoms, cognitive challenges, and poor coping. CBT targets catastrophic thinking, such as, I'll never get better, activity avoidance. If I try to do anything, my symptoms will get worse. Behaviors that perpetuate symptoms. Even small tasks feel risky. I'd rather not push myself. Maladaptive coping that are counterproductive, such as avoiding completely any activity is the only way I can prevent crashes. CBT adds value by reducing psychological contributors to fatigue and cognitive difficulties. It supports functional maintenance and prevents decline, validates the patient experience and strengthens alliance, enhances engagement and shared decision-making, and provides tools for this patient when their symptoms are fluctuating. Key takeaway, CBT is not a cure, but it's one of the few modalities with emerging evidence in long COVID. Next slide, please. Now let's address the question that many of us is asking. What medication is actually helpful? Many of us have prescribed antidepressant not just for mood, but also for fatigue, brain fog, and autonomic instability. Why the antidepressants? Emerging evidence suggests that serotonin depletion may occur in long COVID, potentially contributing to its main symptoms. Observational data coming from early pandemia research have indicated that patients who were already taking antidepressants prior to infection have shown reduced risk of severe outcomes. Such agents have included in research fluoxetine, paroxetine, escitalopram, mirtazapine, venlafaxine, and fluvoxamine. Their proposed mechanism was through anti-inflammatory effects, cytokine modulation, and possible antiviral activity observed in vitro with the fluvoxamine. We do know that antidepressants are effective for first episodes of depression as well as recurrent psychiatric symptoms. In post-COVID depression, the antidepressant provide about 92 clinical response within 4 weeks from the start of medication. 2/3 of patients prescribed antidepressants report improvement in brain fog, fatigue, and dysautonomia. This suggests that antidepressants have a broader benefit beyond classic depression. Next slide, please. Let's talk about guanfacine. Many of us have used it for ADHD or trauma-related hyperarousal. It is increasingly used now for long COVID cognitive and neuropsychiatric symptoms. Guanfacine is a selective 2 alpha-2A adrenergic agonist that strengthens prefrontal cortex connectivity, improves attention, working memory, and executive function, which are domains often impaired in long COVID that are affecting planning, multitasking, and sustaining focus. Why it might help? Guanfacine targets cognitive symptoms that are tied to stress, hyperarousal, or autonomic dysregulation. Proposed mechanism includes reducing sympathetic overactivity, weakening amygdala plasticity relevant for trauma patients, lowering norepinephrine, which is beneficial for patients with PTSD, and anti-inflammatory effects. Use of guanfacine in long COVID remains off-label, and we are still awaiting for clinical trial results. Early reports are encouraging, however, we do not yet have published evidence to support its efficacy. Practical consideration when prescribing the guanfacine: monitor for hypotension as orthostatic symptoms are common, watch for sedation, especially in early treatment, and taper gradually to avoid rebound hypertension. Next slide, please. Stimulants. Many of us have prescribed them for ADHD and narcolepsy. They're being explored for long COVID fatigue and cognitive dysfunction, but their role is uncertain. Evidence is limited, and there are no formal guidance recommended yet. Medication commonly used: methylphenidate, Adderall, Vyvanse, modafinil, amantadine. Few clinical observation: methylphenidate may help post-COVID central hypersomnia and fatigue. Modafinil, Adderall, and Vyvanse have been explored for brain fog and slowed cognition. Amantadine might improve fatigue. Importantly, when using stimulants, we must use critical caution, especially for post-exertional symptoms exacerbation, as the stimulants can improve alertness, cognition, and motivation, but may inadvertently drive overexertion, leading the individual energy and resources to exceed and create additional fatigue, pain, cognitive dysfunction, and autonomic symptoms. This is why pacing education is essential if stimulants are trialed. Next slide, please. Low-dose naltrexone is an emerging therapy with reports of benefit for fatigue, post-exertional malaise, sleep disturbances, and chronic pain. Proposed mechanism includes immunomodulation, anti-inflammatory effects, and reduction of neuroinflammation. About 2/3 of patients reports a good to strong response to a low dose, which is 4.5 milligrams daily. It is used off-label, resulting in limited insurance coverage, requires compounding that is often associated with out-of-pocket costs. Low-dose naltrexone had not shown increased rates of serious side effects when compared with placebo. Next slide. Antipsychotics should not be used for core long COVID symptoms such as fatigue or cognitive dysfunction. However, they do have an important role in treatment of psychosis, severe agitation, agitated delirium, mania, schizophrenia, or significant behavioral disturbances. In acute presentation, olanzapine and aripiprazole are preferred due to lower catatonia risk compared with some alternatives. Key cautions: with any antipsychotic use, consider the risk of QT prolongation, sedation, metabolic effects, EPS, and potential increased mortality in vulnerable population. For patient taking clozapine, be aware that level can significantly rise during acute infection. This requires close monitoring and might necessitate a dose reduction. A brief note regarding the use of low-dose aripiprazole, 0.5 to 2 milligrams daily. The theoretical proposed mechanism was anti-inflammatory, immunomodulatory, and gene expression effects. However, there is currently no clinical evidence supporting its use in treatment of long COVID. Next slide, please. Many long COVID patients coming for evaluations are asking for something for anxiety, describing their nervous system as feeling constantly revved up. The use of anxiolytics and sedatives require nuance given the overlap of symptoms with dysautonomia and sleep disruption, as well as the increased risk of side effects when these medications are prescribed concurrently with hypnotics or opiates. Benzodiazepine should be used with caution, especially in patients with cognitive impairment or PTSD, due to adverse effects such as worsening memory problem and brain fog, worsening trauma-related symptoms, increasing the risk of dependence and tolerance, and potentially leading to respiratory suppression. Their short-term indications are for acute anxiety, severe agitation, crisis presentation. Benzodiazepine are not standard therapy for long COVID, although they might have a role in long COVID-associated mania alongside mood stabilizer or antipsychotic. Gabapentin can reduce anxiety and neuropathic pain, but also may worsen cognition or fatigue and must be used carefully and individually. Neither benzodiazepine or gabapentin are first-line treatment for long COVID-related anxiety. Next slide, please. A significant portion of patients with long COVID are experiencing chronic insomnia. For such patients, the first step should address sleep hygiene and consider sleep medicine referral if obstructive sleep apnea is suspected. Because hypnotics can worsen cognitive impairment, they should use with caution and need regular reassessment. Medication options for sleep onset disturbances, a short-term course of benzodiazepine can be considered. However, this should be reserved only for acute functionally impairing symptoms. For sleep maintenance disturbance, consider orexin receptor antagonist or low-dose doxepin. For senior population, consider trazodone, low-dose doxepin, or orexin antagonists such as daridorexant, lemborexant, or suvorexant. Typical approach: hypnotics can be used nightly for short-term basis, 2 to 4 weeks trial, followed by reassessment. If long-term treatment is needed, consider intermittent dosing 2 to 4 nights per week, and avoid nightly use beyond 3 months. When discontinuing the hypnotics, taper them gradually by approximately 25% per week to minimize rebound insomnia or withdrawal. Next slide, please. Pain is one of the most prominent and disabling features in long COVID. As a psychiatrist, I do not manage chronic pain directly and defer treatment to pain specialists. Non-pharmacological treatment approaches, such as multimodal rehabilitation services discussed above, can help patients and should be considered first line, followed by non-opioid pharmacologic medications such as NSAID, COX-2 inhibitors, TCA, SNRI, gabapentinoids, and local topical like lidocaine or capsaicin gels. Opiates are the last treatment line that should be considered only for severe refractory pain after exhausting the non-opiate strategies. The risk associated with their use includes worsening brain fog, impaired attention, memory, interference with rehab sedation, respiratory suppression, dependence, tolerance, and misuse, which makes the opiates generally not appropriate for long COVID treatment. Mood stabilizers should only be used for mania and not for long COVID symptoms. Keynote: at this time, there are no specific dosing recommendations for treating long COVID with psychotropic medication. Standard dosing remains the typical approach for antidepressant, guanfacine antipsychotics, stimulants, and mood stabilizers. For medication classes such as benzodiazepine, hypnotics, or opioids, the approach is to use the lowest effective dose for the shortest possible duration. Next slide, please. In conclusion, an essential aspect for caring for individuals with long COVID is the early and accurate recognition of its diverse symptoms, including psychiatric manifestation, and the implementation of individualized, patient-centered, multi-model treatment strategies. Because patients experience overlaps medical, psychiatric, cognitive, and functional symptoms, care must be tailored to the person, not just the condition. when we combine careful symptom recognition with empathic, validating communication and collaborative goal settings, we build a therapeutic framework that reduces the stigma, enhances engagement, and supports meaningful functional recovery. Thank you.
Laura, thank you so much. That was great. An excellent timing too. So we've got some time for Q&A, and I'd love to open it up to our audience and to our panelists for any questions that you have for Laura about her presentation. Is there anybody who'd like to go first?
Thank you so much. Can you guys hear me?
Yes.
Yeah. So I think what I'm wondering about, and you got to it a little bit, but I think I've had a couple patients who have also had brain injuries in the past, and it may just be that anytime you've had a brain injury, anything else that affects cognition is going to double impact it. But any thoughts on that connection between kind of post-concussive syndrome or people who have had concussions and then develop more cognitive impact?
It's so the research indicates that a virus invades the neurons, so it adds an additional layer of injury to the already injured brain by the TBI. TBI is disrupting the synapses and the connectivity. The COVID virus probably is disrupting the nervous cell itself, so it adds on the
Okay.
deficit. That's
Okay.
my interpretation. Why?
Yeah. No, that makes sense. Perfect. Thank you.
I had a quick question. As a psychologist, and I'm not, a medical provider. When I'm talking with folks, and they'll often talk about all of these symptoms that they're experiencing, and I suppose it's kind of difficult. I'm sure it's difficult to figure out, is this a result of long COVID? Is this a result of, something different? I mean, even like something like fatigue that you said is one of the primary symptoms. I mean, we know that that can be caused by just a number of things. What would you suggest for a like non-medical clinician who is talking with a patient who is kind of describing a lot of these symptoms? And having distress as a result of these symptoms, what would you suggest how do we talk to them about that? What are some of the suggestions we can make to them as far as maybe a referral, who to go see, how to talk to their provider about it?
So fatigue is one of the main symptoms that it's indicating long COVID, but it's not particular just for long COVID. So you have the chronic fatigue syndrome that also has a similar presentation. These symptoms generally are invalidated in other care settings. So validating their experience will be my first approach. And definitely OT evaluation to bring them into that pace exercise therapy. Probably it helps them learn the level of the fatigue that they're experiencing and how much they can challenge themselves in a day without at the end of the day crashing.
That's so helpful. Thank you.
Hi, Dr. Musteti. I'm wondering, are we going to see TMS or ECT for long COVID? Like, would that happen?
ECT probably not, unless the depression is so severe to the point that it requires that level of treatment. But TMS, it's one of the neuromodality treatment that emerging for long COVID patients. It's still in research, but we may have a win there.
Thanks. Interesting stuff.
I agree.
Yeah, I have a question regarding like and it's probably in the slides, but maybe I just didn't see it. What are like maybe your 2 to 3 medications that are like inappropriately being used that concern you when you get consulted on charts?
Stimulants used at way above maximum recommended dosage. That's one of main concern, because the patient get benefit from the stimulants in terms of attention and focus, and they feel they can push themselves through that moment in time. When the medication wears off, they crash. So the automatic thought process is, I need more, so the dosage of medication should be increased, that I can function better. But it's a vicious cycle. And to respond to you, another one would be the sedative. Because patients with long COVID are unable to function at the level they've been before. They become dependent on family members. Anxiety ramps up, and use of sedative might quiet a bit the anxiety, however, leads to additional layer for the fatigue. So again, another vicious cycle.
So would you only use the justification of the stimulant, like if they were open and actively participating in CBT, to with the idea that they would titrate off of that?
It's stimulants can be used long term. It's there is no contraindication for long-term use as long they are beneficial. However, they need to understand what exactly the benefit is and also the side effect of it. Ramping up the dosage, it's not the actual answer.
I had a question. Listening to your talk and thinking about like my practice as psychiatric nurse practitioner, outpatient practice, and how it's changed across COVID, it makes me wonder, do you think that we are maybe missing more long COVID cases than we were previously when people were testing a lot more frequently? Because I remember like I used to ask, are you vaccinated? Have you had a COVID infection? And I've not been asking that as much in recent years, but just thinking of patients who have presented where it's like kind of new onset depression and some of the like low energy cognitive aspect, cognitive kind of challenges, whatever that looks like for them. And I'm conceptualizing it as like, oh, this is just maybe a, initial new onset major depressive episode. But hearing you speak has me wondering, yeah, could some of that maybe be kind of like post-COVID or post-infection? Especially, I'm just looking at the slides, like as of 2022, over 3/4 of the people in the US have had COVID. Like, I don't know what the latest numbers are. Probably most of us have had it at least once, 2, 3, 5 times, whatever. So, yeah, I don't know if you have any thoughts on that.
I'm assuming that taking a good history, it's what is helpful. And generally, the psychiatric symptoms do not appear in a void. They are associated with the brain fog, the fatigue. So that might be an indicator to ask additional questions about potential COVID infection.
Laura, thank you so much. This was a really great presentation with a lot of information for folks. Just as a reminder, you can find these slides on our website where you logged into this call. So if you would like more information on that, always refer back. So Laura, thank you so much. We're going to